Thank you for joining us today for our webinar. Your commitment to advancing mental health care is truly inspiring. At ICANotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, ICANotes offers a comprehensive solution tailored to your practice's needs. With ICANotes, you can write a flawless note in less than 3 minutes, and without typing a single word. ICANotes was designed specifically to help mental health professionals write comprehensive notes quickly. ICANotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at icanotes.com/try-us.
Welcome, everybody. Thank you so much for being here. As we are just getting started, if you want to drop where you're from and your specialty in the chat, it's always really helpful for me to know what types of clinicians we have in the room and in the space so I can hopefully try to speak to different professional modalities, populations, etc. So please feel free to drop that in there when you have a chance. But we will go ahead and get started on our webinar today, which is documenting a visit. This is the fourth installment of a really spectacular series we've been putting together all around documentation from the very beginning of your work with a client or even before you start working with a client, what do you do? All the way to discharge planning, which we will have next month. So thank you so much for being here. I see the chat being populated with people from all over the place. Wow, a lot of East Coasters. I see California, though, as well, Arizona. Yes, mental health counseling, CBT Act, all the great ones. Thank you. Thank you. So happy to have you all here joining us today. I am thrilled to join you as the speaker for this series. Specifically, my name is Kaylee Kron. I'm a licensed master social worker and a certified grief counselor through the American Institute for Healthcare Professionals. I started my career as a bereavement coordinator and counselor at a local nonprofit hospice. And through that, did a lot of work with individuals navigating deep grief, whether that was through our hospice care or through other circumstances. But it really expanded my ability to really connect with my clients, but also to be able to pull out those pieces of our sessions that meant a lot to be documented. And I think I am such a in the room with the client first kind of clinician that it really took time for me to hone my documentation skills to make sure that in any situation, and we'll talk about the different situations where it's really important to be mindful about what's in your documentation. It took me time to really figure that out and hone it and feel really confident that whatever situation I found myself in, wherever my documentation was being seen, I felt really confident. And so today we are going to dive into specifically when you are in the midst of working with a client, you are having sessions where you're checking in about goals, you're seeing how they're doing, you're connecting more deeply about things that are really stressing them out, what they want to work on, how they're feeling from day to day. You're really in the meat and potatoes of your practice with them. So we're going to talk about how we document those kind of visits. So our learning objectives today is we're going to look at a couple different note-taking styles. I am partial to the SOAP notes. It's also a great feature of the ICANotes software. And it's very easy to use within the framework that I use it. But there's other note-taking styles. So I want to give a little bit of a spotlight to a couple because all of us are different. All of our brains work differently, and it's important to have different note-taking styles so that it fits you. That's the most important, right? Because if you just fundamentally can't stand the way you're taking notes, it's really hard to want to take notes, and we have to. So we're going to go over that. And then we're going to talk about what is the clinically relevant information within a session. And for that, we're going to watch a little vignette of a mock session that we've been following the same client throughout this series. So we'll talk about what do we want to pull out of this session? What are some high level pieces that we discuss within that are relevant to the documentation? We're also going to look at avoiding over documentation and the inclusion of non-essential content. So what do you want to leave out because it's not necessary? And what questions do you want to ask yourself as you're documenting? We're going to have a really great tutorial on how to take that session, think about what you want to put, and then put it within the notes. And we're going to be using the ICANotes software today, which is thrilling. And then finally, we're going to look at ethical standards, how to be accurate, confidential, professional throughout all of your notes, so that if at any point, for whatever reason, appropriate through HIPAA, somebody sees your notes, they understand what you're saying, there's not too much information, and it gives a good snapshot of where you are with your client on any given day. So the first thing we're going to do today is just talk about the foundations of note taking. I think as clinicians, I always say this every session. We are either in the room with the client in the moment. That is what really draws us to clinical work. And then there's people who are really good at note taking. And I bet they're not here today because they don't need to learn about how to do this. I myself needed to learn a lot about note taking because I love being in the room. And the most important thing, though, within that framework is you're in the room, but you also have this little mind of, what do I need to make sure I am documenting? So why do we do progress notes? Why do we even have to do this besides billing purposes? A couple of reasons. Number one, we want to make sure that we are staying on track with our therapeutic goals. We are not meeting with clients off of vibes, right? We have a structure that we follow based on diagnosis, treatment plan, and discharge plan for the future. And if we don't take notes that kind of keep us on track throughout that, we can fall off track as far as what are we working on each and every day. And that can create problems with if you are working on things that are not within the treatment plan or not under specific codes based on diagnoses, treatment plan, etc. We could get into a little bit of trouble all the way down the line with maybe billing. And then also making sure that we're adjusting our plan going forward. We also want to make sure that each session, sometimes you see a client twice a week. Sometimes you see him twice a month. Sometimes you see him once a month. And how many clients do you see in between that time is a lot of stories, a lot of goals, a lot of treatment plans that you're reviewing. And so it really helps you grab a snapshot of what that last session was. Best practice for me personally, I go into my notes from at least the last few sessions to kind of review where were we? What are we working on right now? Let me make sure I'm as fresh as possible within the story of what my client is needing from me and what we're working on. I don't know if you've ever been a client. I always suggest we all as clinicians are clients at some point. Therapy is important for all of us to unload, but I have been in the sessions where the clinician that I was working with didn't remember me, didn't remember my story, needed a lot of reminders. And even though I know functionally that makes sense, that like they were carrying a lot, I as a human being want to know that my story mattered enough to remember it. And so I always walk into every session with that intention of I want to make sure my client knows I care very deeply about their story. I remember, and we're on the same page, and I'm on the edge of my seat to find out how everything went. That feels good. That's a therapeutic alliance. Also the staff of the counseling that I employ. So that is my framework that I work under. And we also want to make sure that within the purpose of the progress notes, we're writing with intent. So are the details functional clinically? And making sure that we're always kind of asking ourselves those questions. Staying within a structure can really help us from just going off on a tangent, from documenting too much, from falling out of scope. It helps keep us focused, professional, and clear. But it also helps us meet our billing standards and make sure that we're not putting things in our documentation that is not appropriate by really staying within a very specific framework. SOAP is helpful. SOAP notes are helpful, and we'll go over that if you're not familiar in the next section. Because it chunks things out. Like, what did you see? What did they say? What did you interpret? What is the plan? And that really helps keep you in line. Otherwise, you can just fall into a over documenting. Okay. We also want to document just enough within the framework of documentation. We want to definitely include any changes to the goals, interventions, and how a client is responding to those things. So we're wanting to make sure that we're having updates to the existing plan that we have in place. What is it? How is it going? Are we moving forward with it? And we want to make sure that we're leaving out small talk, irrelevant details, and any that we're putting personal commentary on. And I say this, it's always our intention to leave ourselves at the door. But it's really helpful to have documentation that has a framework that doesn't really facilitate your personal opinion being documented. It is helpful because we're all humans, right? And I want you to think as you're documenting and you're reading through your documentation each time, would this note be clear to me 6 months from now? That is such a good question to ask because I think, especially if you're a clinician who saves documentation until the end of the week in the evening and you are documenting multiple clients, not best practice, but I know we all get into that sometimes. Being able to reflect back and say, does this make sense from an external perspective of I have forgotten this session completely and I read it? Do I have enough information? Am I clear enough? Do I understand the situation? So always asking yourself that. So the next thing we're going to do is explore a couple documentation styles. As I mentioned, there is not a one size fits all. We all have our favorites within the framework of documentation, which is, of course, thrilling. And we think about it every day, right? Probably not. But we do have favorites. And I think another thing that tends to happen is whoever trains us or wherever we work first or have our internship first, whatever they use, we just end up using because that's what we know. So sometimes we don't do a whole lot of research around what else could there be. There's a whole world of different documentation styles based on your settings, specialty, personal preference. So looking at these multiple systems of documentation can be fun to lean into documentation in a way that's going to work best for you. So the first one that I have mentioned before, and I mentioned throughout, and we'll go through a SOAP note today, which is great, is SOAP notes. So we have SOAP stands for subjective, objective, assessment, and plan. So this is a very structured format, and you can think of it in a box grid of the first is what are the benefits? It comes across, it's really familiar. That's what's really nice about it is it's very clear and to the point. What did you see? What did they say? What do you think about that? Or what is your assessment? And what is the plan moving forward? Is very easy to follow. And it leaves very little room for being misread. And it also helps organize complex sessions really clearly. So there are times when you are met with a client who has had potentially a very particularly hard time in between your sessions, and you are just having a lot of information thrown at you. You're trying to untangle a lot of really complex emotions and experiences and relationships, and there's a lot going on. What's nice about SOAP is it helps you zoom back in. There are drawbacks, though, to that framework can feel to some as rigid and formulatic. And that is fair enough. If working within that very structured framework doesn't work well for you, that's okay. But just being aware that is in essence what SOAP notes are. It also may not capture a narrative flow. So if you're more of a storyteller within your notes. And that is how you 6 months from now can understand what happened. Soap notes might not be for you. So then you might like soap notes if you enjoy structure, clarity. If you are highly collaborative with other professional and providers where people are reading your notes and they are just needing the facts. Often, if you work with a physical therapist, occupational therapist, a physician, a psychotherapist, someone who is doing medication management, they really do just need to know the facts. So this can be really helpful within that framework of making sure everybody is on the same page, just from a very factual, rigid standpoint. Then we have the DAP notes, which are a little bit of soap and a little bit of data. So it blends two things of a little bit of context from the session, but it also pulls in really like interesting data points that'll help you navigate progress. So the benefits of it are they're concise, more concise than soap notes, but it still captures those key elements of therapy by having the assessment plan. And it encourages focus on clinical insights versus what is necessarily said within the session. The drawbacks is that there's a lot of nuance within client sessions, and the storytelling does not really exist here within the same framework that other note-taking styles may have. And insurance providers just flat out do prefer soap notes because it's a little bit more comprehensive with those 4 categories. But you might like DAP if you want a slightly more flexible version of soap notes, but you appreciate efficient notes, like something that takes a lot of information and puts into a very capsuled reading experience. And then also if you're in private practice and your health records, like you want to use this one software and this one type, this can be really helpful because it's difficult to do incorrectly. We also have the GERP note. I think these are fun acronyms. So in general, we're just having a really good time with noises today. So we have DAP, GERP. So we have goal, intervention, response, and plan. And this is a really goal-oriented format. It is focused on progress toward treatment objectives, which of course, and we need that, and to be able to measurably speak to that each time. So this format really works in your favor there. And it always ties back to specific treatment goals. It really keeps you on track as far as what are we supposed to be working on? What did that look like in session? Can be difficult if some health session didn't actually line up with the goals in a way that is very direct. So that might be difficult. And that is definitely a drawback. But a benefit is it keeps the treatment goal in the front. So anything else is secondary within the GERP note format. It's also great for like really measurable outcomes. Think about groups where it's not really like what you're working on is not really an ongoing process, but you're doing short-term therapy or counseling where you have a defined timeline. Like you only have 6 sessions. And so you want to have those measurable outcomes really clearly outlined and checked in upon after each session. And it also highlights clinical interventions and client responses. So you're seeing in real time, how is this treatment plan working the person that I'm working with? The drawbacks, of course, are that it is just less narrative about how did the session go, what the client was bringing external to the treatment plan. We're human beings, and so we don't function within a treatment plan on the outside. And so there may be a nuance to the session that gets a bit lost within these notes. And if that is important for you to have, then the group notes are probably not for you. And also, I think within that same framework is it doesn't really capture like that rapport building, that therapeutic alliance, which can be very important to some clients. And if that is not something that you document on necessarily. It could be something that falls by the wayside within session, especially if that's not your personal style of therapy. But it could be best fit for clients. So it's just, there's no middle ground here. You might like GERP if you are working in a setting that is very goal oriented, outcomes oriented, short term therapy, counseling. I'm trying to think of what's the best example of a really short term. So if you have a specialty where you're like, yep, I work with clients for 10 sessions. That is what we have. And we work within this framework and we have these treatment goals. Pop it in the chat because I am really curious about different groups and those frameworks because I know a lot of clinicians have open-ended clients where we don't necessarily have a plan for the end. But I am curious about if GERP notes sound resonant to groups that are more short term. Substance use. Thank you. So I was like, I want to say substance use treatment, but I've never personally worked in that. I just have worked with, like, in tandem with. And so that it sounds right to me. But so thank you, Mackenzie. Then finally, we have narrative progress notes. This is for the storytellers of the room. This is a free form style and it captures sessions within a narrative or storytelling framework. It allows a lot more nuance and process and commentary from the clinician. You can really capture a more dynamic session within the narrative style because there's a lot more allowance as far as what you're supposed to put in there. It's less prescriptive. So it allows space for kind of that therapeutic process and for you to really show, that stream of thought and conversation throughout the session from a perspective of the clinician experiencing it in session. And it's very flexible. The drawback to that, though, is it's time consuming. I don't know how many clients you all see every day, but I've never had, because I was a grief counselor and there's 3 or 4 is a maximum there. But I know some counselors or clinicians, therapists see 10 or more clients a day, especially if you're in private practice. Thinking about doing narrative therapy within that framework and that much storytelling can be overwhelming. And that's going to result in falling behind on notes. It is really hard to standardize the notes that you're taking. So from one session to the next, you might have a different flow to your storytelling to where those two notes don't really match up with each other and one doesn't facilitate an understanding of the other. And unfortunately, because it's narrative and you're just reporting on what's going on from that storytelling perspective, you may miss elements that are essential for insurance and legal. So be mindful of that. So if you're going to use this style, maybe have a couple bullet points in there that meet those needs as well. But you might like this if you are a really depth-oriented clinician, if you work psychodynamic trauma therapy, if the story is deeply important to how that plays into your treatment plan and your outcomes, then this might work best for you. If rich detail and the process work is, again, such a main component of how you do your practice, this could work very well. And if you are not under insurance, if you don't have to worry about that, congratulations, first of all. I love that for you. But if that's not something you're tied to and you're able to be more flexible, this could potentially be true with people in private practice who are private pay. That could work. Okay. So now we're going to dive into the vignette. But first, I want to give a little background on the client that we're seeing today. And we are not going to watch a full session because as sessions are 45 to 60 minutes. So we just clipped out a few key components that I thought might be helpful to watch together, which will gear us up for our documentation section. So we are seeing our client. Her name is Jenny. She is a mother. She's a stay at home mom and a wife. She is in her later 30s. Her two children have now started elementary school, and she's feeling a lot of grief around her change in purpose, what she what her role is within the family system and then within like society in general. And then as a result of kind of aging, and that's not to say late 30s is aged by any means, but her body is changing and she's experiencing differences that are hard for her to grapple with. So we're having some body grief, we're having some body image issues, we're having role change grief. And so we are in mid session. Some of our goals are to figure out who she is outside of being a stay at home mom and wife and to feel more neutral slash positive about her body and what it can do, focusing more on that as opposed to how it's changing with time. So, a few things I want you to keep in mind is just observe how I, as the clinician, reflect, listen, track progress in little key moments. It doesn't take a lot of time, but through verbal and nonverbal cues, making sure that we're always touching the treatment plan a little bit and making sure that we're staying on track with what did she want to work with instead of just chatting about how her week went. I also want you to look at behavioral observations, which can then become objective data that we're going to put in our soap note. And then note how clinical impressions are formulated in real time. So, how is the clinician responding to what the client is saying clinically and not just from a perspective of, that was so great. I'm so proud of you. I love that for you. But that is clinically based within the framework of our work together. So, we'll start that video. Hi, Jenny. It's good to see you again.
Hi, Kaylee. How are you?
I'm doing well. I am so curious to see how your week went, especially around the journaling and movement we discussed.
I did manage to do journaling twice. So I wrote down some of those affirmations that you mentioned, but it really felt weird writing down my body deserves kindness. It was kind of hard to believe it, even though I was writing it.
Yeah, thanks for your honesty. It's powerful insight to look at how those affirmations are like genuinely feeling inside. It's a little awkward as you get started, but thank you for trying. Can you tell me more about how you were feeling while you were writing it?
It really did make me more aware of how much I do criticize myself every day, especially in the mornings when I first get up, I'm getting ready for the day. I noticed that I'm pointing out a lot of the negatives to myself.
Yeah. Awareness is a powerful tool in this process. Noticing those patterns is a big step toward interrupting them.
Yeah, I didn't really realize how automatic a lot of those thoughts were.
Yeah. Would you be open to trying something new in the morning, like a short self compassion meditation to shift that routine?
Sure, I'd be open to it.
And how did movement go this week?
I actually went golfing this week. I didn't worry about how far I walked or how well I played. I was just really focused on like how I felt being out in nature. So it was awesome.
That's a huge win. It sounds like the experience really aligned with what we talked about, values based movement that feels good and is not performative.
Yeah, it was really freeing. I look forward to going back next week.
Awesome. You're building these empowering experiences, so it's exciting to see you keep them going. Last time you mentioned wanting to rediscover your identity beyond motherhood. Do you have any updates on that?
I actually signed up for a watercoloring class. So I used to paint in college and it was really weird doing something just for me, but I was really proud of it. Yeah,
That's incredible. It sounds like a meaningful step toward reclaiming that sense of self. How did it feel emotionally afterward?
I felt inspired. It was a little spark of who I used to be. So it was great.
It's beautiful. I want to keep reflecting on those sparks. So maybe after each new experience, could you jot down how that made you feel?
Yeah, I could probably do that.
Great. Before we wrap up, what do you want to focus on this upcoming week?
So I'm going to focus on the morning meditations, and I'm definitely going to make time to go golfing more. And yeah, I'm going to work on focusing on those reflections after my watercolor class next time.
Perfect. I'm excited to hear about how it goes at our session next week.
Awesome.
Okay. Not a lot to it, right? So we are having a conversation. It is warm. We're checking in. That is, and how we express that warmth of glad you're doing well. And then continuing to tie that back to the treatment plan. And so thinking through how that vignette went, I want you to wonder that client update and we're going to do soap notes for this one. So maybe if you feel like jotting down some ideas, some thoughts, and then we're going to watch a video that's actually going to walk us through the answers to these. Feel free to participate or just witness and view and learn. But the first one is when we're thinking about the client update, what was relevant within there? I know that we didn't add a lot of details to the session, mainly because we want to make sure we're getting to tutorial of documentation as opposed to just watching a mock session. But what was relevant and what belongs in the subjective section? Just subjective. What did the client say? What did they do? The next is those nonverbal cues. So, what did you observe from Jenny as far as she was sharing how things were going? There were times when she said, I felt weird. Like, it feels a little awkward to say things like, my body deserves kindness, or to write those things down. Those are real things. But what did you observe within the construct of what she was saying and how she was saying it? And then what is objective within that? What did you objectively see? And then what did you interpret instead? Because we're also talking about concepts of body image and identity, which can touch on us personally as well. So this specific case vignette can feel very personal. It can feel hard to separate personal beliefs and feelings about the content from what you are objectively seeing. So I want you to be mindful of that as Jenny was navigating these like identity things and body image things. What was objective and what was interpreted by you through the lens of personal experience? And then next, what interventions were used? So how would you describe this clearly in the plan section of the SOAP note? What did we talk about doing? What were the suggestions? What were the takeaways from this session that you would then put within the plan to circle back on for your next session? Okay.
So I had a couple people say, sorry, it takes background, but I had a couple people say about the soap note. So I do want to show the soap note. Is now a good time to do that, Kaylee or Angela?
Yeah, absolutely. Thanks.
Fantastic. Okay, I'm going to share my screen and take over. Let's just share my entire screen. All right. And thanks for people for pointing that out. Great job there. So there's our soap note right there. So I can go right into our soap note. Click in that. Here, we're going to have the tabs that are going to come up: subjective, objective, assessment plan, and the fitness. And so in the subjective area, I'm going to have that symptoms reported button. So I can go through there and I can click on whatever is going on with that particular client. So if there's depression, I could say that there's fatigue going on and there's hopelessness and irritability. I could say that there was some social withdrawal, which I believe last session she had that. I could talk about suicidal thoughts or feelings of worthlessness there as well, maybe concentration problems. So I'm able to address all of those and also talk about current stressors right here, like problems at work, and there is personality conflicts at work, and maybe problems in relationship. So there has separation has been threatened. Right. Anytime in here you can talk or you can type. Well, thanks to you're able to do that without any issues whatsoever. Then I can move over to the objective. And in the objective, I have symptoms that are being observed. So you can go into more detail with that. I can talk about behavior. So I could say like her self-care. Again, maybe it was reduced right? At that time. Functioning at work was absolutely forced. So Maybe there's been some impulse issues like being poorly controlled. And then I can address sleep there or medication compliance. Like they have stopped their medication compliance. I can then go into assessment, and this is my mental status exam. Now, before I just clicked the button and I did the normal mental status exam, which is wonderful when you have folks that are doing well, right? That's great. But let's say that perhaps she's not doing so well here. So I can say maybe here in her appearance that she is sad in her appearance and very distracted and tense throughout our interview. Right. I can say affect. I could say it was normal, but I'm not. The same with mood. I am going to say that her mood is depressed. And it's good to talk about how you see that depression, right? So there's facial expressions and general demeanor. I could say that hurts her body posture and attitude. And these are things that you as a clinician can pick up, right? AI cannot pick up someone's body posture or their general demeanor, right? This is your clinical assessment skills, and you're showing that absolutely that she is depressed. I can go in here under affect and say that it's flat. Her affect is flat. I can talk about that maybe she's not psychotic. I can say if there's suicide, you can definitely address this here. They have plans, if they have ideas, but no plans, or if they have ideas and intent. So, or wishes to be dead. I'm going to say not suicidal. I'm going to say that she is not homicidal. You can go in, especially if you're dealing with the geriatric population, or even people that are in the early phases of like dementia, neurocognitive disorders. I can do it in MSc on them. So we're able to do that if you want. I'm going to say that cognition dementia right now is normal. You could talk about IQ and really drill down on that. I can talk about insight and judgment. If you were working in an inpatient hospital system and you were dealing with a joint commission, you are going to want to address insight and judgment. Not only are you going to want to put poor or fair, you're going to want to talk about why. So maybe if you're in an outpatient setting, I would say that their insight could be her insight was good, it was normal, but maybe her judgment is good. It's normal because she appeared for her appointment today. You could actually type that in. As far as anxiety, I can say that they have and drill down on that more, or there's no signs. And then I could say if she was fidgety and restless during the interview and there was poor eye contact. I'm able to do that. If you had rating scales and they completed them in the portal, they will pop into ICANotes. And so you can literally just click rating scales and it'll bring the previous rating scale in, which is really nice. I can go into plan. And there's that justified level of care. It's really good for getting you more sessions. But I can also link the treatment plan in like I did before. So I can just pick the treatment plan that I'm going to pull from, maybe for anxiety. I can select certain interventions there, drop those in, the ones that I'm working on. Be really careful when you're working with insurance, especially don't pull in all of your short-term goals or interventions because they might say you didn't have time to go through all of that. And then I can say she's doing good. And then we're going to continue this current plan. And I can link that right in. I also have my psychotherapy there that I showed in the previous note where I can go in and I can talk about session goals, what we're dealing with, like communication skills, coping skills, and interventions there. And of course, as I showed before, you can add your own into here as well. So that makes, again, time go really quickly with your notes. And then I could finish. I could put my diagnosis in, enter my service codes. You can even, if you're doing labs, things like that, you're absolutely able to do that. Here's our private notes, which is really nice. Information blocking the Cures Act. And I do compliance for ICANotes. So I'm really focused on that. Unless it's a psychotherapy note, patients can request their notes. And more individuals, that's been a log for almost 2 years now, but more individuals are figuring out about that and they're wanting to see their notes. So if there's something that you need to know about, but you don't necessarily want to put it in the note, you can enter it in the private notes section there for you. All right. And then I will compile the note and I could easily sign that note. And then I have a really pretty, very thorough soap note. All right. All right. That's it. So I'm going to stop sharing my screen here. Thank you so much. Thank you.
Thanks, Sober. That was really helpful.
Absolutely. Absolutely. Yeah. I can absolutely, Brooks, I can go through and show you that the therapist tab. I'd love to do like a one-to-one with you. I don't want to take any more of Kaylee's time here, but I can absolutely do that through the therapist tab. And Mary said, so this is using AI. Will it generate a note for you? That's a really good question. I'd like to answer that just real quickly. So our shrubs are written by clinicians. So what you have in there are clinician state. Now, what we are introducing to up and coming things that ICANotes, one is coming out a little bit sooner, is where it will take your note, even if you use our shrubs or you put your information in there, and make it a little bit more readable through AI. You have the option to use that. We're not going to force AI on anybody. The second thing that we have coming up and we're really excited about is ambient listening. So for those of you who want to use it, you don't have to. That's the great part with ICANotes. So we do have this really two nice features coming out. I know some people love AI, some people don't like it at all. And that's the great thing with ICANotes. You decide how you create. So, all right, I'll hush now and let Kaylee get back to it. Thank y'all.
Me so much. That was really helpful. And we got more than we thought we were going to get. So that's awesome. There's what I think October shows so well is how many different styles of note taking you can really do within the software that's built in. You can also customize. So it's really fabulous. If you want to learn more about the software, please feel free to set up a demo call. We are going to do a couple more slides to just end cap the note taking questions to ask, what to leave, what to keep. So I want to make sure that we're really touching on what to include and what to keep out, knowing that not everything belongs in your notes. And it's really important to be mindful of what you are putting in and what you are keeping out intentionally, because it can be overwhelming. It can open you up to liability, and it can also lead you off track of the treatment plan if you're documenting things that don't necessarily belong. So what does belong? We want to make sure that we're keeping client statements within those, especially in reference to the ones that are tied to goals and symptoms, so that we're really tracking similar things across multiple visits. The next is we want to make sure that we're updating symptoms and changes in functioning, as well as interventions that were provided and how the client responded to those interventions. As noticed during the vignette, Jenny and I talked about interventions that I suggested in a previous session that she was like, that felt weird. And so I would document that didn't feel great and she didn't love that activity. So we came up with a new idea. Would you be willing to try this or that? Would you be willing to implement these things? So you document when you add new potential interventions or things to try out and how the client is responding. We also want to always make sure that we're adding clinical reasoning and assessment of the client's progress. So we're not just reporting on here we are, but we also want to add our clinical perspective and how we're assessing how the client is doing, how they're responding to the interventions that we're putting in, how they showed up that day, and the path forward. And then, of course, if there's any safety concerns or mandated reporting, that needs to go in your documentation as well. What to avoid? Of course, we want to leave out any irrelevant personal details. I personally love stories about people's dogs. That is probably the highlight of every session I have. If you want to bring your dog, I'm thrilled. However, that probably doesn't belong in the documentation unless there is some connection of the dog to therapy outcomes, interventions, etc. It could be a emotional support animal, things like that. Of course, we can leave in. We also want to keep out jargon or slang, any judgment. Again, when we were talking about the content that was included within this vignette, how we can have personal feelings about body image, grief, identity work around parenthood, etc. Making sure that we're keeping out any personal feelings that we're having, but also any personal judgments we're having about our client. I would also venture to say that if you're documenting that your client's being dramatic, you may want to do some reflection with your clinical supervisor to just like unpack why that's coming through within where you're documenting. I think it's really important to be mindful of personal feelings towards your clients that may be coded as a judgment. Also, emotional venting or sarcasm. People unfortunately say, oh, I might as well just kill myself. And that's not something you want to document because they're not actually saying that they're going to harm themselves. It's just something that they said in sarcasm or being dramatic, or not being dramatic, but in hyperbole. So always things to keep in mind of what to leave out. It is not helpful. So you want to run it through this relevance test quick filter. So as you're documenting, you're typing things out, you think, does this inform treatment? Would another provider need this information to continue care if you disappeared? This person still needs help. They don't want to start over. So do they have enough information to continue to move forward? Not that would really happen. We don't just disappear. And number 3, would I be comfortable reading this in court? I personally have had to read documentation in court. It is very uncomfortable. And even if you have the best documentation in the world, just always be mindful that eyes have the potential to be on this, and you may need to be responsive to the things that you're writing. So from that lens, really consider, would this be something I want to read out loud, potentially in front of my client? Going over ethics very briefly, as we always do, we want to make sure your notes are clinical, legal, and ethical. Ethics is one of my favorite topics to cover within every webinar because I think it's just so important that we keep ethics at the forefront of our practice. So the first thing we're going to talk about is accuracy. Document what has occurred, not what you're assuming or what your opinions are about the session. We want to use client quotes when possible and avoid any interpretation without any evidence to support what you are saying. Confidentiality, we want to make sure, keeping that in mind of, would I be comfortable reading this in court? Would I be comfortable giving this over if I was subpoenaed, etc.? Please don't include sensitive or identifying details about third parties, stories shared by the client. We are working with that individual one-on-one. And so any new person you introduce, try to keep it as vague as possible and only include what's essential to care to ensure that you are, again, working for that overall treatment goal and keeping clinical integrity. And then we also want to avoid over-documenting trauma. You are going to hear a lot of details. You're going to absorb a lot of hurt, a lot of pain. You're going to be able to feel that energetically in your session. Not every single thing that is said needs to be documented because, again, we're thinking about, if this gets read, what are the consequences there? And was this necessary to put every single detail? Probably not. And we want to always keep professional tone, neutral, respectful over all else, and free from bias. We want to use clinical language that is not emotionally or could be interpreted as a personal opinion. And as a reminder, we always want to make sure that our notes represent professionalism whenever possible. Okay. We got right under the wire. And I know that there has been some questions in the chat around the software about how to use it, what the different customizations are. It's incredible. Angela has linked those to schedule a demo or to ask those very specific questions. People who are far more qualified than me to answer. So please do that. I am just wanting to make sure that I get any other questions answered. I did see one further up around what is your preference on which type of notes you use based on what session you're in. So if it's your first session, would you use more narrative? If it's your like an ongoing client, would you keep it more brief? And I think in the grand scheme, go back to the other webinars where we talk about the first 3 kind of sessions that are like formatted differently than a general session. They have other reporting requirements that kind of are above and beyond any of these. that to answer your question, I think it depends on which session you're referring to. But I do think in general, clinicians tend to stick to a format that works best for them, regardless of which session they're in. And that really helps hold the integrity of the storytelling from one session to the next. Because if you're hopping from one type of note taking to the other, it can feel like one session has a lot of information about one thing and then another has a lot of data. And those things don't necessarily go together, maybe within the framework of the story that is being told. So I would just be mindful about switching it up, but certainly test a few and figure out what you like best. But otherwise, our time has come to an end, and I just deeply appreciate you all being here. I hope to see you all at the next session where we are going to talk about ending our relationship with our client's termination and offboarding. And how do we plan for that? How do we document for it? So I do hope to see you all there. And in the meantime, please take care of yourselves. Bye.